Hi, I'm Dr. Alyssa Dweck. I'm an OBGYN in New York, and I'm so pleased to be here today on behalf of Innovation Compounding to talk to you about pelvic pain, mainly broadly from a gynecology perspective. I will be talking about a broad overview of pelvic pain, differential diagnosis, treatment and management options broadly, but mainly this is from the perspective of a frontline gynecologist in office. I will exclude emergencies and also obstetrical etiologies of pelvic pain. So the etiology of pelvic pain can be complex and have various etiologies. Oftentimes, the gynecologist is the first stop in the workup of pelvic pain. And so it's really important that we address and know about all different possible etiologies so that we can address it properly. In general, the differential can be broad and it can be non-gynecologic in nature. And that's why it's important to have an overall grasp of different reasons for pelvic pain. First, acute pelvic pain tends to be for less than 3 months duration. Chronic pelvic pain, more than 3 months duration, and generally not cyclical or not related to the menstrual cycle. Pain can be diffuse or focal, it can be sharp or dull, it can be sporadic or intermittent, it can be cyclical or constant, and these are all important historical measures that we have to keep in mind. Pelvic pain usually refers to pain below the umbilicus, in the lowest part of the abdomen and between the hip bones. But of course, this can radiate to the legs, to the back, to the vulva, to the vagina. So we need to keep all of these things in mind. A thorough history and physical, of course, is vital, and appropriate lab work, blood, cultures, imaging, all of those modalities are going to help with diagnosis. So I know this is likely very general and well known to all of you in the audience. However, I just thought I would put up this broad history survey from up to date to really guide questions when it comes to eliciting the source of pelvic pain. Definitely, we want to know a general medical history, age, sexual history, medical history, and whether there are any inciting or relieving factors. In regard to physical exam with women who have pelvic pain, it is focused. In other words, doing a breast exam or a throat exam, likely unnecessary when this is a problem-focused visit, but certainly we want to know what somebody's general appearance is. Do they look toxic? Do they look comfortable? We want to do a back exam, an abdominal, a pelvic, and sometimes even an extremity exam. In regard to the differential that has to do with gynecologic health, we're going to broadly discuss some of the most common issues that might be leading to pelvic pain. So first, dysmenorrhea or pelvic pain during menstrual cycles. This can fall into two categories, primary or secondary. Primary simply means that there's no obvious identifiable cause for pain during the menstrual cycle or just before the menstrual cycle, whereas secondary dysmenorrhea suggests an underlying cause, and we will get into those. But these are things like endometriosis or fibroids or cysts. In general, dysmenorrhea refers to pain occurring with the menstrual cycle or just beforehand. Primary dysmenorrhea is typically thought to be due to prostaglandin release from the uterine lining right before or during menstruation. Prostaglandins tend to cause uterine contractions, which then may cause some very temporary squeezing or hypoxia to some of the blood vessels in the pelvis, and that leads to pain. In order to diagnose primary dysmenorrhea, pain has to be cyclical. So it has to be predictable, it has to be based on the cycle. 50 to 90% of people have discomfort during their menstrual cycles. The majority of these people are young women with primary dysmenorrhea, but some older women will, or not so young women, will suffer with secondary dysmenorrhea due to other issues such as fibroids, which mechanically can cause some discomfort, or they can cause a little bit of blood flow alteration leading to pain. endometriosis, which of course causes bleeding throughout the pelvis and scar tissue formation. And dysmenorrhea usually starts about a day or two before the flow and then persists up until the end of flow. But usually it really dissipates within 12 to 72 hours of onset. Diagnosis is going to be really with a good history, a good physical, possibly some blood work, cultures to rule out infection, imaging to look for some of these secondary causes of dysmenorrhea, and then treatment will be based on that. In terms of primary dysmenorrhea, one of the main helpful hints for patients can be anticipatory guidance. In other words, keep a menstrual app or a calendar so you can expect the pain at a particular time each month and kind of preempt it with medication or whatever lifestyle changes might be helpful. In regard to other treatment options for dysmenorrhea, birth control pills in the right candidate can be very, very helpful. Analgesia from over the counter, particularly those that interfere with prostaglandin release and association. And then other women are resorting to heating pads, TENS units, surgical intervention, other hormonal manipulation, and even surgical intervention if necessary. In regard to menstrual pain, we also have middle schmerz. And in fact, this can be so severe that it has actually brought women to the emergency room in my experience. Middle schmerz, which simply means painful ovulation, is basically recurrent mid-cycle pain that is usually in women with regular cycles. And it is theorized to be caused either by normal follicular enlargement just prior to ovulation or to follicular bleeding or leakage of fluid at the time of ovulation. The pain is usually mild, but can be notable and last for a couple of hours or even a day or two. It can be unilateral, but it can switch sides based on different months. And timing is key for diagnosis. Although this pain is usually self-limited, many women treat themselves with heating pad, analgesia from over the counter, and even oral contraception in an effort to suppress ovulation. In regard to endometriosis, I think the scariest thing is actually how common endometriosis is. So it's estimated that 10% of reproductive age women are affected with endometriosis, and the most easiest way to describe this is that these are endometrial lining cells that basically occur outside the uterus. So this hormonally responsive tissue implants itself throughout the pelvis, and it responds to hormone each month and can cause bleeding in the pelvic cavity with no escape, and then form scar tissue as a result of that. So this can be quite uncomfortable. This other notable statistic about endometriosis that it takes up to 7 years to diagnose this. So women will come in with complaints of pelvic pain that's been ongoing, not diagnosed by anything other than just you have cramps, suck it up. And actually, this can be very disconcerting to these women who are really suffering. Diagnosis is also often one of exclusion, where lab work, exam, imaging really doesn't show anything definitive. And then laparoscopy, of course, is the most definitive way to diagnose, but oftentimes it's a diagnosis of exclusion without surgery. And treatment can be accomplished either with birth control pills, pain medication, GRNH agonists, or even surgical intervention. Another source of pelvic pain in the gynecologic realm, of course, an adnexal mass or ovarian cysts. Again, very common. Ovarian masses are the most common type of adnexal masses in the female population and are identified in about 8 to 35% of premenopausal patients and 3 to 17% of postmenopausal patients. They can cause pelvic pain or pressure. They can cause discomfort during intercourse due to mechanical pressure, but pain or pressure sometimes doesn't even exist, and these are found incidentally. Ovarian cysts are typically diagnosed on imaging and oftentimes will resolve on their own, but certain nuances really need to be kept in mind when it comes to ovarian cysts. One is size, because cysts greater than 8 to 10 centimeters have a propensity to torse or twist, and they can cut off the blood supply to the ovary. And this is an acute emergency that needs to be dealt with surgically. In addition, rupture can be very uncomfortable, even though it's often self-limiting. And then, of course, we always worry about ovarian cancer, which is rare, but because it's typically diagnosed so late in stage, it's something that we always have to have in the back of our minds. In regard to treatment options, many ovarian cysts or adnexal masses will spontaneously resolve. Some will need oral contraception for suppression of ovarian function, and others need surgical intervention. And next slide, I just wanted to relay this more complex table from Up to Date, just discussing the differential diagnosis of adnexal masses so that you have a thorough list to peek out. Fibroids or leiomyoma are very, very common. In fact, they're the most common benign pelvic tumors in females. They are smooth muscle tumors. They are predominantly benign. They typically present as mechanical pain or pressure, but because fibroids require a large blood supply, they can degenerate over time, cause infarction, and this can be super painful. Fibroids also cause painful periods, so this is something that might be found in the workup of painful periods, as we spoke about before. And they also can cause really heavy periods and clots. Most of the time, these can be diagnosed by history, by physical, and by imaging, and they can be treated either expectantly. Many times they'll start to shrink or at least remain stable post-reproductive age. Sometimes they require surgical intervention or with intervention done by an interventional radiologist, like embolization to block the blood flow to fibroids. And oftentimes we just have to treat the pain and heavy bleeding with oral contraception just to treat symptomatically. Infection, a very common cause of pelvic pain for women. BV, or bacterial vaginosis, is the most common cause of vaginitis in reproductive age women. 40 to 50% of cases of vaginitis are due to BV. And BV is not thought of as an STI, but rather is thought of due to an imbalance of good bacteria, or lactobacilli, in the vagina and anaerobic bacteria that tend to overgrow and overwhelm the vaginal biome, causing a discharge and an odor and pelvic discomfort. Some women will have discomfort with urination, but some women let this go for a little bit or get it regularly or recurrently and can get some lower pelvic pressure as a result of BV. BV can be treated with antibiotics, but it also can be prevented with a good probiotic that is geared towards vaginal health. It also can be prevented with lifestyle changes, including using condoms, particularly if you have multiple sexual partners, including avoiding all the disruptors that can really interfere with a natural and normal acidic vaginal biome, like fragrant products, douching, and certain other hygiene products that many women use. UTIs can cause pelvic pain, and we're going to get into this in a further slide. STIs like gonorrhea and chlamydia, which are quite common. In fact, gonorrhea is the second most commonly reported communicable disease and the second most prevalent STI in the US, with 700,000 infected patients noted per year in the US, which is pretty overwhelming. And there's more and more resistance. But both gonorrhea and chlamydia can cause lower pelvic pain and lead to a more significant infection called PID. PID, or pelvic inflammatory disease, is 85% of the time related to an STI or BV. So these things are best treated and recognized early. Risk factors for PID, of course, include the usual: multiple sexual partners, lack of condom use, being less than 25 years old. In fact, this is the reason for the standard recommendation to check all 25 and younger women regularly for gonorrhea, chlamydia as part of their annual GYN check. As far as diagnosis, this is typically done by history and culture and ruling out other reasons for pelvic pain, but PID is typically treated with antibiotics and sometimes surgical management, especially if there's a tubo-ovarian abscess present. In regard to an algorithm for treatment of PID, I thought I would include this. I'm not going to go through it, but this is also up to date and helpful, especially now in light of so many antibiotic resistance. Pelvic organ prolapse. This is quite a mysterious cause of pelvic pain in lots of women, but in fact, the pain is real. 2.9% of pelvic pains or women prevalence is noted with symptomatic pelvic organ prolapse. And this is basically a herniation of pelvic organs like the bladder or the rectum or the cervix and uterus, or even the vaginal walls that bulge into the vaginal cavity, and they can cause pulling and pressure and pelvic discomfort. Risk factors standard are having had multiple kids or really big kids and instrumented deliveries. There is a genetic propensity toward pelvic organ prolapse. Obesity is a risk factor for organ prolapse, and even race and ethnicity are related, with Black women having a lower risk and white women having a higher risk. In general, this is an overwhelming problem for women in terms of their distress and quality of life, but it also leads to more than 200,000 surgical procedures in the US annually. And since many women don't even report their pain as a result of pelvic organ prolapse, you could imagine that there's actually much more of a physical burden for women. Diagnosis is usually made by history or physical. In my neck of the woods in New York, we typically send most of our patients with organ prolapse and pain as a result of that to a urogynecologist, and treatment might be afforded with certain lifestyle changes like weight management, Kegel exercises, physical therapy, a pessary to mechanically hold things up, or even surgical repair, as we spoke about. But this can cause a very vague pelvic pain, so it's important to keep in the back of your minds. Again, just a schematic of the pelvic floor muscles. It's complex in there, but any of them can become weakened and cause bulging of some of the pelvic organs. Again, another schematic from a different view, suggesting how complex the pelvic floor muscles are. In terms of chronic pelvic pain, this affects 6 to 25% of reproductive age women globally. And keep in mind, chronic pelvic pain means more than 3 months duration of pain. And usually this is pain significant enough to interfere with day-to-day quality of life for women and causing stress and distress. I'm sure you have all seen these women in your practice, and it can be quite frustrating for both patient and practitioner alike. Most common causes of chronic pelvic pain include pelvic adhesions, irritable bowel syndrome, musculoskeletal causes, including pelvic organ prolapse and endometriosis. And of course, treatment involves pain management, but more than that, addressing the underlying factor. In regard to common other conditions, particularly non-malignant conditions that can cause chronic pelvic pain, I've included this more comprehensive list. So on to obstetrics, which I'm not really going to speak about. I think that when a woman comes in to your office with significant pain, the first thing to rule out is a pregnancy mishap if they're of reproductive age or there's a chance of pregnancy. So ectopic pregnancy always needs to be thought of in someone with a positive pregnancy test and pain. A threatened abortion and complete or spontaneous miscarriages, of course, has to be thought about when a woman comes into your office and she's she's pregnant and is having pain. Usually ultrasound will be helpful to really narrow this down. But one nuance that I think is really important, because we've all read about this and some of us have seen this, is the transgender female to male patient who comes in with pain but still has all of the traditional female organs and hasn't had gender affirming surgery, because pregnancy is possible if they are having sex with a male partner. Just something to ponder. Next would be urologic causes of pelvic pain. Again, the most common is going to be a UTI. UTIs are incredibly common. Most women will have at least one UTI in their lifetime, and many have recurrent UTIs. Certainly, there are acute, simple cases of cystitis and more complex cases, but in general, it's the standard symptoms: painful urination, frequency, urgency, and that suprapubic pain that is really overwhelming and can come on quickly and be quite severe. These days, most of us can diagnose a UTI based on history, even without examining a patient, and prescribe antibiotics, remotely or via telehealth. But if a culture is available, that would be very helpful to guide treatment, especially with so much resistance out there. E. coli, of course, still being the most common microbial cause of cystitis. Some of the treatment preventative options to help prevent UTIs in those who are prone to them would be the PACs and cranberry concentrated supplement on a daily basis. There is some literature to suggest the PACs and cranberry supplements can make the bladder more slippery to UTIs, or due to being more slippery to E. coli, so that the adherence can't occur. D-mannose has been helpful and shown in some studies to help prevent recurrence. And probiotics, because if the vaginal health is healthy, the urinary health will naturally be healthier and optimized based on their proximity. Next slide. Kidney stones, again, these patients are usually obvious because they're in so much discomfort, but some of them might have small and chronic kidney stones that present as pelvic pain. 1 in 10 females will have a kidney stone by age 70. And again, presentation might be urinary complaints, but pelvic and back pain or CVA tenderness might be the presenting symptom, blood in the urine, and a feeling of grittiness to the urine as well. Diagnosis is typically made by history, physical, urine testing, and CAT scan, and then off to the urologist for treatment and potential preventative measures. As far as interstitial cystitis, we are probably seeing more of this than we even realize. This is a very poorly understood, painful bladder condition, possibly autoimmune, possibly brought on and triggered by some sort of preceding event like a significant infection, but still it's common in young women, and it is a cause of chronic pain disorder, usually presenting as lower suprapubic pain and urinary frequency. Again, these women are ones who present to the office over and over, causing frustration for practitioner and patient alike, and typically off to the urologist for workup with cystoscopy and further testing. There are some thoughts that diet and lifestyle modification might help with this discomfort, but other times much more aggressive treatment is needed. Finally, gastrointestinal issues are things that we see in the GYN office all the time. And oftentimes there's a overlap in symptoms between GYN and GI symptoms. So it's important to have a familiarity. Appendicitis, probably the most urgent one to make sure we diagnose. Again, it's not that uncommon. 100 in 100,000 person years are affected, and the most common age category 20s to 30s. Again, this typically presents as your standard right lower quadrant pain, loss of appetite, nausea, vomiting, and is usually accompanied by fever, high white count, and CAT scan findings. But how many times have we been going back and forth between, do they have an ovarian cyst or do they have appendicitis? And this is a really common distinction that we have to make as gynecologists. Oftentimes, these women will come into the office and then re-present to the emergency room a day later with worsening symptoms. So it becomes clear, but it is something that we can pick up on the earlier side if we look into it. Other GI issues, of course, these women will head off to the gastroenterologist, but gastroenteritis, celiac, lactose intolerance, constipation can cause significant pain, and the rest of the list goes on. Again, GI referral most helpful. So with that, I'm going to close. I know that was a very broad and quick overview of etiologies and broad strokes when it comes to pelvic pain, but these are things I know I see in my gynecologic practice day to day. So I thought this would be a really helpful review. Thank you.
Thank you for joining us today. We hope that you've learned some valuable information to expand your knowledge and further grow your practice. The Revelation Institute was designed to help providers across America learn more about different therapeutic lines and join pharmacists and providers together to deliver the best possible patient care. If you've enjoyed our educational video today, we encourage you to sign up for our future topics. If you have questions or want more resources or materials for today's topic, please email info@revcustomrx.com to connect with the local pharmacy specialist. Thank you again for listening today.